Hi everyone, my presentation is based on intrahepatic cholestasis of pregnancy. Some information about this disease. Globally, intrahepatic cholestasis of pregnancy, also known as ICP, is a form of cholestatic liver disease that's unique to pregnancy. It typically affects between 0.3 and 5.6% of pregnancies. The frequency in the U.S. is widely due to its diverse population. Prevalence of ICP has been reported to be 5 times more higher in took pregnancies than in singleton pregnancy. ICP can also be more displayed in seasonal variations as well as more incidents to the weather, such as colder seasons or chilly winter months. ICP could be more common in some ethnic groups than others. The environmental, hormonal, and genetic factors could all also have an impact on how it develops. ICP can be more seen in Swedish, Chilean, and Arakan Indians as well. With ICP, genetic factors do play a role in the development of ICP due to strong family members. This can range between percentages of 10 and 16% of mothers, sisters, daughters that had experienced ICP prior during their pregnancy. Some risks that can occur to the maternal as well as perinatal and fetus. After crossing the placenta, maternal bile acids can accumulate in the fetus and amniotic fluid, which can cause life-threatening issues. ICP is more of a concern when it comes to mothers. The main primary risk factors to the fetus, although rare, could be sudden intrauterine fetal demise, meconium-stained amniotic fluid, spontaneous preterm delivery, and after birth, the fetus may have, the baby, could be admitted to the NICU. ICP is primarily based on and diagnosed on clinical presentation. Often patients will call in reporting their palm, hands, and feet, irritation, itching. Primarily, you'll see this in the late second, early third trimester. On top of clinical presentation, laboratory labs are highly important, especially bile acids. Here are some common differential diagnoses that could be mistaken for ICP, given the clinical presentation that patients can often describe. Atopic dermatitis as well as allergic reactions are the top common ones. And then you do just want to rule out acute fatty liver of pregnancy as well. So therefore, clinical presentation of patients, laboratory values, mainly liver function tests, are highly important when it comes to diagnosing ICP. As mentioned prior, when excessive maternal total serum bile acids are present in the third trimester, combined with pruritus, a clinical marker of ICP. It is possible to rule out other disorders that was mentioned in the previous slide. Primarily, total serum bile acid with the cutoff value is the most sensitive and specific measure when it comes to diagnosing ICP. Overall, only 10 to 20% of patients will have mild hyperbilirubinemia, and in some extreme cases, jaundice. Ultrasound imaging can be done to rule out additional causes, such as cholestatic or biliary tract disease as well, also known as gallstones. Treatment plan for ICP is primarily focused on resolving or relieving patient's symptoms. So starting off, you can start off with antihistamines, topical ointments, but the primary goal is to reduce the risk of perinatal morbidity as well as mortality and relieving mother discomfort, which are the main objectives of therapy. Pharmacological route, UDCA is preferred, although the starting dose is not known, it is appropriate to start patients at 300 milligrams twice a day and increase to 300 milligrams to 3 times a day until delivery. It's highly important to monitor patient symptoms as well as labs when it comes to deciding when to give birth. It's important to weigh the danger of fetal death against potential hazards associated with preterm delivery. If delivery needs to be discussed, it should be noted that delivery should be between 36 and 37 weeks, according to ACOG. And here are my references, and that includes my presentation. Thank you.